Hello guys, welcome to Dr. Sam's anatomy classes. Here I'm going to solve this question paper you are seeing is from Atal Bihari Vajpayee Medical University of Lucknow. ABVMU. This question paper was meant for students admitted in MBBS 2021. This question paper is of main exam for these students, held in January 2023. So this question paper is of anatomy paper-1 part-2. My previous upload was of anatomy paper-1 part-1 of the same exam. To watch that video, you can tap the link popping above, or the same link is provided at the end of this video. So this one is paper-1 part-2. As you know, the ABVMU question paper pattern, here also you are seeing is a long clinical question, which is a structured question with subparts, and together that makes 15 marks. Then there are 3 short answer questions of 5 marks each, that makes 15 marks, where you have to write less than 500 words. And then there are 5 ultra short questions where you have to write less than 100 words, 2 marks for each, and that makes 10 marks. Lastly, there are 10 MCQs, 1 mark each, that makes 10 marks for MCQs. Okay, let's begin solving this question paper. Question number 1 is long answer question. A 38-year-old woman visited a doctor with complaint of hard, painless lump in the upper outer quadrant of her left breast. On examination, the doctor found that the breast was fixed and the axillary lymph nodes were enlarged. Actually, the better way they should have written is that on examination, the doctor found that the lump in the breast was fixed and axillary lymph nodes were enlarged, because the entire breast is not going to be fixed. Radiograph of the vertebral column showed irregular shadows in the bodies of L1, L2 vertebra. Now this will be a metastasis most probably. So answer the below mentioned questions. What is the probable diagnosis and why was the breast fixed? So one thing is, because they mentioned is hard. Remember, a malignant tumor on palpation is hard and firm. If it would have been a soft tumor, that's like a fibroadenoma. Generally, we call it as breast mouse, a slippery tumor, and it's not fixed. So fixedity, hard, and even painless. Remember, the neoplasia is generally painless. If it would have been painful, then it would have been an inflammatory cause, generally because of infection, pain, and fever also. Here they have mentioned it's hard and painless and it is fixed. So all this is indicative of carcinoma breast of left side. And why was the breast fixed? So you should know that the cancer forming cells have an uncontrolled mitotic activity. So there is rapid multiplication of such carcinogenic cells. So there is rapid multiplication of such tumor cells, and they have this property of getting infiltrated, invading the adjoining tissues. So such tumor cells, they will first of all invade the adjoining structures like the suspensory ligaments of Cooper, the septa within the breast, the skin overlying, the fascia overlying the bed of the breast, and even then infiltrating and getting fixed to the underlying muscles forming the bed of the breast. And it might even infiltrate into the ribs and the intercostal spaces. So that's what is the property of a carcinoma, is that such cells get seeded anywhere they reach, even to the distant organs, by means of lymphatics or venous spread. That's called metastasis. And wherever they get seeded, they form a secondary carcinoma over there. So why was the breast fixed? I have told you now. Describe the morphology of the breast is given in detail in your books. You should read it from there. Blood supply of the breast is quite often asked. You should read it from the books. Remember, it is supplied mainly by the branches of the axillary artery, superior thoracic artery, then pectoral branches of the acromiothoracic artery and lateral thoracic arteries. And even from lateral side, those are the perforating branches from the posterior intercostal arteries, and from medial side, those are the perforating branches of the anterior intercostal arteries. You should explain whatever you are writing with the help of diagrams. Remember, in such long questions, diagrams is a must in anatomy. So support your explanation with the help of diagrams always. Then give a detailed account of lymphatic drainage of the breast. This is a super important question from long time back. It, you can assume, is 100% going to be asked in one of your exams throughout the 1 year tenure of your MBBS. Maybe in your sessionals, terminals, pre-universities, or even in the university exam. So lymphatic drainage of the breast you should learn by heart, and it's given there in detail in your books. You have to write its applied anatomy. That means we're talking is about the spread of cancer through the lymphatics as well as through the venous channels. So you have to describe here about the internal mammary group of lymph nodes, the axillary group of lymph nodes, primary, secondary, tertiary group of lymph nodes, right? The order of the spread of carcinoma through the lymphatic channels, reaching to the supraclavicular group of lymph nodes, posterior intercostal group of lymph nodes, paravertebral group of lymph nodes, even to the subphrenic, subdiaphragmatic group of lymph nodes, and the lymphatics associated with them. And remember, carcinoma breast may also spread via the segmental veins. Those are the intercostal veins over to which the breast is resting. So immediately below to the breast, those are the segmental veins. They communicate posteriorly to the internal as well as external vertebral plexus of veins. Remember that the internal vertebral plexus is a vertical channel of veins which is valveless. So there are very much chances if the carcinoma reaches there, it might ascend above and reach into the brain, and it might even descend down to reach the vertebral bodies. As they have mentioned here in this question that the carcinoma has reached to form irregular shadows in the bodies of L1, L2 vertebra, right? So I have just supported you in this question, but it's a must that you read this topic in detail from the books. Then question number 2, short notes questions. First one here is the floor of the fourth ventricle. Again, a very commonly asked question. I'm not going to explain it here. It's very well given in books. You should read it from there. Visual pathway and visual field defects. Remember the optic nerve, especially it's asked in clinical scenarios, like in case of pupillary reflexes, consensual eye reflexes, accommodation reflex, visual body reflex, and now the visual pathway. This visual pathway, when you will have to express, you need to draw the diagram. And I believe you know that from retina, the optic nerve, optic chiasma, optic tracts, LGB. Now this one is a geniculate pathway. The conscious visual pathway is a geniculate pathway which passes through the lateral geniculate body, and finally the optic radiations reach to the primary visual areas, and from there to the secondary visual areas 17, 18, 19. You have to draw this and explain the visual field defects caused by lesions at various places of this visual pathway, like the hemianopias, quadrantanopias, bilateral, unilateral, homonymous, everything you have to explain, and it's given there in the box. Remember, there is also a non-geniculate pathway, like few of the fibers from the optic tract, they do not reach to the LGB, they rather reach to the pretectal nucleus of the midbrain, right? And that actually serves the purpose of subconscious visual pathways, like the accommodation reflex, pupillary reflex, visual body reflex. But you need not mention about that. You are actually asked here is about visual pathways. So explain that and its visual field defects. Question number 2, C. motor speech area of Broca's and sensory speech areas of the Wernicke's. I have made videos for these two special areas, Broca's 44, 45. Wernicke's, the area actually is not very well specified, so you can know the details about these areas, the motor and sensory speech areas, as well as the relevant aphasias. I would suggest to watch the videos on Broca's and sensory areas. I have uploaded the link in the description box. Next is question number 3, short answer questions. Explain why median cubital vein is preferred for collecting blood samples and for giving intravenous injections. One reason, it is a fixed vein because it has a perforator reaching down below to communicate with the deep veins, and that perforator actually pierces the roof of the cubital fossa that is being formed by the bicipital aponeurosis. So it does not slips easily. This is the main reason. And other reasons include it is superficially placed, it is easily accessible, and there is good of patient compliance. Patient also easily cooperates in this type of venous sampling. Next is carpal tunnel syndrome, a super important question. Compression of median nerve within the carpal tunnel, mainly because of the dislocation of lunate, then myxedema, obesity, tenosynovitis, tendinitis. There are several reasons, and the deformity will be ape-like hand or the ape thumb deformity. There's a video for this. I have given the link in the description. You can watch it from there. Then enumerate the arteries taking part in formation of Circle of Willis. Super important question. I believe everybody reads this question before going for the exam. Remember, it's a communication between the branches of the internal carotid and the branches of the vertebral arteries. And also an anastomosis between the arteries of left side and the right side, means bilateral anastomosis also takes place. So that's a circle formed by the anterior cerebral artery, internal cerebral artery, middle cerebral artery, anterior communicating branch, posterior communicating artery, posterior cerebral artery. All this together form a circle of Willis placed in the interpedunclar fossa over to the diaphragma silly. Well, I'm just giving some important points, but you need to read from the book. Enumerate the 4 examples of hyaline cartilage. Very easy, simple question. There are always few questions to support you to pass the exam. So hyaline cartilage you must have read. The main example which generally you get to see in your histology labs, that's the trachea, the semicircular rings. They're example of hyaline cartilage. Not only in the trachea, but in the primary, secondary, tertiary bronchus as well. Other example you can write is the costal cartilages. Then remember the articular cartilage covering the articular surfaces of the synovial joints. That also is a hyaline cartilage. Then the cartilages contributing in the nasal septum and lateral wall of nose, part of the external nose. There also it's hyaline cartilage. And there's no harm if you write extra examples like the growth plate, also called physis, which is present between the epiphysis and metaphysis, the long bones. And the joint, is called the primary cartilaginous joints because they undergoes synchondrosis and get fused later on. So the joint disappears. Such joints are called synchondrosis. So these are the few examples. You can read more from the book. Enumerate the branches of axillary artery. Super duper, as I told you, there will be some questions which will help you cross the 50% marks boundary. And make sure you know this fact that you need to score at least 40% marks in each paper separately. Like in paper 1, you should score above 40% marks, and in paper 2 also you should score above 40 marks. And together, combining paper 1 and paper 2 marks, you should score above 50% marks. I hope you know this. So if you are scoring 45 and 55 marks in the 2 exams, then you will be pass. But if you are scoring 38 and 62 marks, you will still be fail. So enumerating the branches of axillary artery, 1, 2, 3 arteries, superior intercostal, then you have is thoracoacromial artery, lateral thoracic artery. The third part will give rise to anterior posterior circumferential arteries, and the longest branch, that is the subscapular artery, is given out from the third part. For this also I have made a video and link is given in the description box. You can watch the video. Lastly, question number 4, that is multiple choice questions. Question number 1, muscles attached to the medial border of the scapula are all except serratus anterior, rhomboideus major, minor, teres major. Remember, serratus anterior is attached to the costal surface of the medial border, while rhomboideus major, minor, these are also attached on the medial border but on the dorsal surface. However, teres major is attached onto the lateral border dorsal surface. So the answer here will be teres major. Question number 2 is Erb's palsy is due to injury of upper trunk of brachial plexus, lower trunk of brachial plexus, C8 root of brachial plexus. It is due to dislocation of shoulder joint. Super important and easy question. So the answer here will be upper trunk of brachial plexus. There's a point where the two roots of C5 and C6 spinal segments, they join to form the upper trunk, and from there the two branches, nerve to subclavius and suprascapular nerve, they are arising. Some books have even written that it's a point where 6 nerves meet. At the same point, this upper trunk actually diverges out into two divisions, the ventral and the dorsal division. Okay, so that's a point called Erb's point, and this Erb's palsy is due to that, and the deformity is the porter's tip hand or the policeman tips deformity. Question number 3, the brain stem consists of all of the following components except midbrain, pons, cerebellum, medulla oblongata. Again, an easy question. You know that brain stem comprises from medulla, pons and midbrain. However, cerebellum is not a part of brain stem. Remember prosencephalon, mesencephalon and rhombencephalon. Here I would like to explain you parts of the CNS confined within the cranium has been divided into 3 parts: forebrain, midbrain and hindbrain, right? Forebrain is prosencephalon, then you have is mesencephalon, and the hindbrain is called the rhombencephalon. Now this prosencephalon is further divided into 2 parts, that is telencephalon and the diencephalon. The telencephalon is placed laterally, forming the cerebral cortex of the 2 cerebral hemispheres, and the cavity is called the lateral ventricles. The diencephalon is placed in between the 2 telencephalon, between the 2 cerebral hemispheres, and the cavity of the diencephalon is called the 3rd ventricle. And this diencephalon consists of thalamus, epithalamus, subthalamus, metathalamus, hypothalamus. Then you have is mesencephalon. Now this mesencephalon is made up of midbrain, and the cavity of this mesencephalon is called the cerebral aqueduct of Sylvius. Then you have the hindbrain made up of pons, medulla and cerebellum, out of which pons and cerebellum are together called metencephalon. However, medulla oblongata is called myelencephalon. Question number 4. All of the following are subdivisions of diencephalon except thalamus, mammillary bodies, metathalamus, subthalamus. So while I was explaining MCQ number 3, there I already explained you about the parts of the diencephalon. Remember once again that the diencephalon is made up of thalamus, hypothalamus, metathalamus, epithalamus, subthalamus. So out of that, you have already been given these choices: thalamus, metathalamus, subthalamus, right? Hypothalamus and epithalamus also is included in the diencephalon. But mammillary bodies, you can mark it here. Mammillary bodies are actually, they're part of hypothalamus. Okay. Question number 5. Clavipectoral fascia is pierced by all of the following structures except cephalic vein, thoracoacromial artery, medial pectoral nerve, lymph vessels from the breast. To explain you this, I have uploaded a video on axillary artery and its branches. There I have also covered up this important topic of clavipectoral fascia in detail. You can watch the video in the link provided for the detailed explanation of this question number 5. Well, right now, just remember that the structures piercing clavipectoral fascia are the cephalic vein, thoracoacromial artery, medial pectoral nerve is not there, lymph vessels from the breast. Apart from that, there are lymph vessels from the thumb and the lateral portion of the forearm. They also perforate the clavipectoral fascia along with the cephalic vein, and the lateral pectoral nerve also perforates this clavipectoral fascia, right? So the answer they have asked is except. So the answer will be medial pectoral nerve, which directly supplies pectoralis minor, perforates this muscle, and then reaches to supply pectoralis major on its undersurface. Question number 6. Which of the following two muscles contract together while climbing a tree? Latissimus dorsi and trapezius, teres major and teres minor, teres major and pectoralis major, latissimus dorsi and pectoralis major. So remember, when they have used this word climbing, you should remember about a muscle called climbing muscle. Which muscle is that? That is called latissimus dorsi. So already two choices have been ruled out because you know that latissimus dorsi is a climbing muscle. Then the two options left is pectoralis major and trapezius. Pectoralis major will not have a role here because you know that is a adductor and a medial rotator of the arm. So trapezius, you know, is a muscle which helps to elevate the shoulders and helps in lateral rotation of the scapula to bring your arm above the head, above 90 degrees, right? Trapezius along with serratus anterior. So they could have replaced trapezius with serratus anterior also, then also it would have been correct. So the answer here will be latissimus dorsi and trapezius. Question number 7 is fracture of which carpal bone is prone to avascular necrosis? Lunate, scaphoid, pisiform, hamate. Again, a video on carpal bones I have made and I have attached the link in the description. You can watch it from there. So answer here will be scaphoid. And if it is asked which segment of the scaphoid after fracture will undergo necrosis, proximal or the distal? So remember, it will be the proximal portion. If this is a carpal bone, there's a two carpal bones. Generally, the blood supply is like this in most of the population. But sometimes the blood supply to the scaphoid is like this, completely from the distal end. So what happens in this case? Fracture of scaphoid will lead to AVN of the proximal segment. Question number 8. Which of the following structures consists of both projection and commissural fibers? Internal capsule, pyramid, cerebral fornix, or crus cerebri. So, you know, projection fibers are running vertically, connecting the high areas to the areas down below, either in the brainstem or in the spinal cord. And commissural fibers communicate the areas of the two cerebral hemispheres. There is another group of fibers called association fibers, which communicate between the area of the same cerebral hemisphere. So here in the internal capsule, you have a lot of amount of projection fibers. Pyramid also is a part of this projection fibers. Even the crus cerebri is where this projection fibers descend down. Corticospinal fibers. So cerebral fornix. So fornix, you know, is a C-shaped, that's called curvy linear bundle or an arched bundle of white fibers. This bundle is composed of myelinated association fibers, projection fibers, as well as commissural fibers. So the cerebral fornix contains all the three type of white fibers. Question number 9. Term urothelium is used for transitional epithelium, pseudostratified epithelium, simple columnar epithelium, simple cuboidal epithelium. This is very easy. Urothelium, as the name suggests, it lines the tract which is followed by urine. That's why it's called urothelium, right? So it is present in the major minor calyces, the linings of renal pelvis, ureter, urinary bladder, reaching up to the proximal portion of the prostatic urethra in males and even the proximal portion of the urethra in females. So that's urothelium, which is actually also called transitional epithelium. Question number 10. Infection of index finger spreads to the mid-palmar space, thenar space, radial bursa, dorsum of hand. So remember that long tendons from the index finger and the thumb, they are part of thenar space, that is the lateral one-third space of the palm, while the long tendons from the middle ring and little finger, they pass down into the medial two-third space of the palm, that is called mid-palmar space. And the synovial sheaths for the middle three digits is restricted to the digits only, while the synovial sheath from the little finger continues as ulnar bursa, which spreads out in the palm and even reaches into the forearm space of perona, passing below the flexor retinaculum. Similarly, the synovial sheath of the long tendons of the thumb, they continue down and reach into the forearm space of perona through the carpal tunnel, and that is called radial bursa. So remember that infection of the ulnar bursa leads to hourglass deformity. While here in this question, they have asked about the infection of index finger spreads to. As you know, the long tendons from the index finger, they pass through the thenar space. So the answer here will be thenar space.